Assalamu alaikum. My name is Shahroz Asif and my roll number is BP1650209 and my group number is group 38. The topic which is assigned us is adult enteral nutrition. Let's talk about the brief in our adult enteral nutrition. What is enteric nutrition? Enteric feeding refers to intake of food through the gastrointestinal tract. The GI tract is composed of the mouth, esophagus, stomach, and intestine. Enteral feeding may mean nutrition taken through the mouth or through the tube that goes directly to the stomach and provide the nutrition. In those patients who are unable to take the food through the mouth, a person on enteral feeding usually has a condition or injury that prevents eating or regular diet by mouth, but their GI tract is still able to function. Being fed through a tube allows them to receive nutrition and keep their GI tract working. Enteral feeding may make up their entire caloric intake or may be used as a supplement. This is the diagram through which we can take enteral nutrition through the nose, through the gastrostomy options and jejunostomy. Now let's talk about the classification based on duration of feeding. There are two types, which one is starting with the first one, which is short-term feeding, in which usually administered a nasogastric, nasoduodenal, or nasojejunal tube. Long-term feeding, in long-term feeding usually administered as a gastrostomy and jejunostomy tubes. Indications for enteric feeding. Malnourished, unable to eat up to the 5 to 7 days. Normally nourished patient, unable to eat. Adaptive phase of short bowel syndrome. Increase needs that can't be met through the oral intake. Example, burns, trauma, aspens. Now let's talk about the contraindications for enteric feeding. Inability to gain access, hemodynamic instability. The third one is high output proximal fistula, intractable vomiting or diarrhea may cause paralytic ileus, intestinal obstruction, severe GI bleeding. Expected need less than 5 to 7 days if malnourished or 7 to 9 days if normal nourished. Let's talk about the case study. The 72-year-old male patient was admitted following a fall of 2 to 3 meters onto his head onto a concrete surface, resulting in a severe TBI. TBI is traumatic brain injury. He had no significant past medical history and was fit and well prior to admission. A CT scan of the head showed a right acute subdural hemorrhage, subarachnoid hemorrhage, left frontal and right parietal contusions, a base of skull fracture. An extraventricular drain was inserted in theater for management of raised intracranial pressure. The patient was intubated, ventilated, sedated, and paralyzed on admission to the ICU. Prior to admission, the patient was well nourished with a normal dietary intake. Weight was 72 kg, height is 1.78 meter, giving a BMI of 24.8 kg per m square. Nutritional requirements were calculated by predictive equation and estimated to be approximately 2000 kilocalorie, 95 gram protein per day. Now starting with the soap notes. First we will discuss about the subject. The gender is male, age is 72 years, weight is 75 kg. Chief complaints severe TBI due to the fall of 2 to 3 meter fall onto his head. Medical history, no significant medical history and was fit and well prior to admission. Medications, an extraventricular drain was inserted in theater for management of raised cranial pressure. This pressure is due to the brain injury. The patient was intubated, ventilated, sedated, and paralyzed on admission to the ICU. Prior to admission, the patient was well nourished with a normal dietary intake. Weight was 76 kg, height which is 1.78 meter, giving a BMI of 24.8 kg per m square. Nutritional requirement were calculated by predictive equation and estimated to be approximately 2000 kilocalorie 95 gram protein per day. Now come to the object. The CT scan of the head shows a right acute subdural hemorrhage, left frontal and right parietal contusions, subarachnoid hemorrhage, a base of skull fracture. Assessment. Patient condition is critical due to the head injury. A CT scan of the head shows trauma brain injury may increase the intercranial pressure and may also cause swelling. Malnutrition may increase the risk of developing infection. Increase number of ventilator days and length of ICU admission and extend length of hospital stay. Mortality rates have been shown to significantly improve with each 10 kilocalorie per kg increase in intake up to the approximately 25 kilocalorie per kg. The likelihoods of death for TBI patient who were not fed within a 5 days of injury was double that of patients who were fed. For those patients not fed within a 7 days, the likelihoods of death is increased by 4 times. There are, however, many challenges to feeding the TBI patient. Enteral tolerance is often suboptimal due to the effect of sedation, paralysis, and raised intercranial pressure. Patients are hypermetabolic with studies showing a 40% increase of basal energy, expenditures of post-TBI. Protein requirements are also raised and patients should be fed at least 1.25 gram per m square body weight. Now come to the plan. The plan which is consists in a 7 days. Starting with the first day, feeding was started via an orogastric feeding tube using the standard ICU feeding protocols with a polymeric 1.5 kilocalorie per ml feed at 50 ml per hour. Gastric residual volume increased throughout the days up to the 450 ml for hourly. The unit feeding protocol stated that the gastric aspirate should be replaced up to 250 ml and the remainder discarded due to the discarding of gastric aspirates and meet target nutrition requirements. The patient was commenced on regular metoclopramide and erythromycin as prokinetics. Prokinetics are those which increase the GI motility and increase the contraction of the stomach. Now let's talk in the second day, initial dietetic review due to the ongoing how high gastric residual volumes and failure to meet target enteral feed volume. The dietary recommendation changes the patient to whey, which is a protein-based nutrition and its name is peptamin HN, which is 1,500 ml per day to provide 1995 kilocalorie 99 gram per protein. In third day, the patient remained sedated and paralyzed. His gastric residual volume were reduced to minimal amounts and his bowels were opening with laxatives and suppositories as per the unit bowel protocols. As his target feed volume was being achieved, the dietetic plan was to continue with the current feeding regimen. The patient remained on regular prokinetics. In the 4 day, paralytic medication had been stopped, gastric residual volume remained minimal, and the patient bowel were opening regularly. Therefore, the feed was changed back to a 1.5 kilocalorie per ml polymeric feed at 1300 ml per day. Dietetic review was requested as gastric residual volume had increased to approximately 254 hourly despite continuing to receive regular metoclopramide and erythrocin. If the patient was vomiting and his bowel hadn't opened for the last 24 hours, the feed rate was reduced by the nurse staff to 30 ml per hour. The feed was therefore changed back to the peptamen at 1500 ml per day. Gastric residual volume had reduced to between 0 to 160 ml for hourly. Sedation and ventilation were being weaned and the patient was beginning to wake. Feeding was continued with peptamen but increased to 1750 ml per day due to the reassessment of nutritional requirement. The new feed regimen provided 2188 kilocalories and 110 gram protein per day. Now let's talks about the discussion. The use of 100% whey peptide feed in this patient enable nutrition requirement to be met via the gastric route without the need for post-pyloric feeding. As is often required in this patient group, patients with severe TBI often have gastric feeding intolerance due to the abnormal gastric emptying and the altered gastric function. Secondary to increased intracranial pressure and use of opioid-based sedation, gastric tolerance improved following initiation of the whey-based peptide feed, ensuring nutritional goals were met. Thank you so much.